Hello everyone, my name is Jing Wang from ISMB. My poster name is the clinical response of Upadacitinib and Risankizumab is associated with reduced inflammatory bowel disease anti-TNF inadequate response mechanisms. Inflammatory bowel disease consists primarily of ulcerative colitis and Crohn's disease, which are characterized by chronic relapsing inflammation in the gastrointestinal tract. Although anti-TNF therapy was a breakthrough for IBD treatment, up to 40% of IBD patients are primarily anti-TNF treatment inadequate responders, and another 30 to 40% lose response within 1 year treatment. JAK1 inhibitor Upadacitinib and IL-23 inhibitor Risankizumab are efficacious in IBD patients who are anti-TNF inadequate responders. But the mechanism mediating the response of UPA and RISA are still unknown. In this study, we first identified the molecular and cellular mechanism related to TNF-IR patients based on 8 bulk transcriptomics data sets from IBD patients treated with anti-TNF therapies and 1 UC single-cell RNA-seq data with 51 cell types. We developed the network-based bulk data integration pipeline and identified 7 TNF-IR upregulated modules related to the innate immune response, interferon signaling, and tissue remodeling. Because 3 of our 8 transcriptomics datasets also include control and post-treatment samples, this dataset can be used to validate the anti-TNF mechanisms. As shown in the figure, expression of most of the module were reduced to the level of control subjects in TNF responder patients, but not non-responder patients after treatment. Next, we apply a deep learning method to estimate the cell fraction of bulk sample based on the UC single-cell RNA-seq data, and identified 6 TNF-IR upregulated cell types related to inflammatory fibroblasts, post-capillary venules, inflammatory monocytes, macrophages, dendritic cells, and cyclin B cells. These cell types can also be validated in the 3 datasets with normal and post-treatment samples. To cross-validate molecular and cellular mechanism, we built the anti-TNF mechanism network. Module M1 was an adaptive and innate immune modules that was highly related to all immune cell types. Module M2 was significantly related to cyclin B cells, and Module M3 was associated with macrophage, inflammatory monocytes, and dendritic cells. Module 5, 6, and 7 were tissue remodeling modules, highly related to the inflammatory fibroblasts and post-capillary venules. Finally, we determine whether UPA and RISA had the effect on anti-TNF mechanisms based on the UPA and RISA RNA-seq data from 2 clinical trials. As shown in the figures, UPA was associated with a significant decrease in the expression of most TNF-IR upregulated modules in JAK1 responders, but not JAK1 inadequate responders and TNF-IR patients treated with placebo. In addition, 4 of 6 TNF-IR upregulated cell types were significantly decreased after Upadacitinib treatment in JAK1 responder, but not among subjects treated with a placebo or among JAK1 inadequate responders patients. We observed the similar findings from RISA data. Collectively, this data suggests that Upadacitinib and Risankizumab affect the TNF inadequate responder upregulated mechanisms, which may account for their clinical response among TNF inadequate response IBD patients. Thank you for your attention.